So welcome you all to our weekly virtual program. In this COVID era, we are trying to organize this program so that we can convert the distancing to socially connecting. Today, we are going to discuss on some topics of radiotherapy of rectal cancer, and it will be a 1 hour session. So there will be no presentation, but a discussion. So we have a local discussant, Dr. Mostafa Aziz Sumon, who is assistant professor and head of the Department of Oncology in Kurmitullah General Hospital. And you heard him talking last session. Definitely you will be enjoying his discussion. The next person is this man, who is a courageous man. He dared to go to this device and to fly a journey from Gulshan to Dhaka Medical College. And then so he didn't only complete there, he is a knowledgeable man because he gave lectures almost in many of our sessions. He is a welcoming man because when some of our colleagues like Dr. Mostafa, Dr. Shahana, or Dr. Shamiran went there, they enjoyed the wonderful hospitality. So he is a welcoming person. And he is a very reasonable person. Whenever we give a call, he responds. Like today, he responded. He is Professor Alessio Morganti, who is a professor of radiotherapy in Bologna University. And he is a very respected person in the whole world for GI malignancy. And I was introduced to him in a program where he was supposed to run a weekly program on GI malignancy. And he is a very passionate person, because my first introduction was, gentleman called me from Italy airport was when he was about to take a flight, and I told him that your program is canceled. And he went back to his house, and interestingly, after 1 month, he came again to attend this program. So this proved that how much passionate he is and supportive he is. So for all your support, a big thanks to Professor Alessio Morganti, and today he is our overseas discussant. Professor M.A. Hai, who is the chairman and also the patron of our organization, and he's the inspiration. And with his presence, we always enjoy all the programs. So I will request Hai sir to formally start the program so that we can move on to our program.
Thank you, Kamal. Bismillahirrahmanirrahim. I'm happy that we got personality like Alessio Morganti with us today. We shall learn many things from him today. And also we have amongst us Dr. Zahid from England. Assalamu alaikum, everybody. Let's start immediately.
Thank you, sir. Thanks, Zahid, for joining. I know you are a hardcore medical oncology guy, but believe me, even in the radiotherapy, some medical oncology issue will come. We cannot ignore our colleagues because it is a multidisciplinary team. Thanks for joining. Alessio, Dr. Zahid is a man from Bangladesh, a brilliant medical oncologist working in UK. So today, other than the presentation,
with the question, so I need to check these issues, whether this is really extramural without any extramural involvement or not. This is not very clear over there. So with this confusion, let's proceed. So if it's a adenocarcinoma, low-lying rectum involving the anal canal, so I think as its location is the lower rectal part, so though it is not extramural involvement, but some mesorectal nodes are there. So it's a relatively high risk group of patients. So the intention of my treatment is to achieve a clinical response or sphincter sparing procedure. So I will opt for long course radiation therapy along with capecitabine. And I will definitely, I will prefer a boost radiation therapy, as you have advised, that 50.4 additional 5.4 gray boost with capecitabine. I am okay with it. And regarding the technology VMAT, I'm a little bit discussing regarding this point, because in this case VMAT is okay, because as the rectum involved in the lower part of the rectum, so we might include the external iliac or the inguinal nodes. So in this case, VMAT might be a good option. I am agreed with your prescription. I am agreed your prescription.
So regarding capecitabine, will you give all through the time or only on the day of radiotherapy? Concurrent capecitabine.
No, I will prefer to give capecitabine only for those days where I am going to give the radiation therapy, then the 5 days a week.
Okay, now Dr. Eliseo, may I have your comment here? Because when we use infusional 5-FU, it is a continuous infusion. But when we are giving capecitabine, we are giving, most of us are giving on the day of radiotherapy. Do you have any comment on it? Dr. Eliseo.
Okay, about radiotherapy prescription, I totally agree. The prognosis of this patient is not nice. I don't think we have any possibility to reach a sphincter saving procedure unless the patient will have a wonderful clinical response. But generally here is not a tumor close to the anal sphincter, is a tumor invading the anal sphincter. So this is a big problem. But in any case, is a patient with high risk of local recurrence, and I totally agree with Dr. Sumon that the staging is unclear. You know, MRI is very good, but also putting a finger in the rectum of this patient can give us some information about the mobility of the tumor mass. It sounds like a T4 tumor because it's invading the anal. So I will not struggle about definition of extramural extension. It's a big tumor, it's invading the anal canal, it's producing hydronephrosis, so it's probably a T4. And in this situation, I agree about giving the most aggressive treatment. My only observation is that if you have availability of a VMAT, in my center, I would use the same dose, but with a simultaneous integrated boost, because in this way you can improve, again, further the efficacy of the treatment. Also because rectal cancer is a strange disease, it grows very slowly, very, very slowly. You know, for screening, colonoscopy is performed every 5 years because it's a low-growing tumor. But proliferation of cells is very fast, paradoxically, because it's a tumor losing a lot of cells into the lumen of the bowel, but it's a fast proliferating tumor. So as fast as we are in delivering the treatment, as better is the clinical result. So I would consider the possibility to use a simultaneous integrated boost. Totally agree about capecitabine, in spite of 5-FU. You know, I'm crazy about this particular system that is the CS that we try to use daily. And as you well know, CS is common sense. So I would prefer capecitabine, generally speaking, but I have to talk with the patient to see if he's reliable, because I prescribe this tablet, but am I sure that he will take this tablet every single day at the right time? Otherwise, I will opt for 5-FU. If he's completely not reliable, I will give him a bolus 5-FU. So I'm sure that he's receiving concurrent chemo.
Thank you. So you have answered the boost issue also, SIB issue. Now let me ask you a reverse question. If I was treating the patient with 3D CRT, would you be happy?
The question is for?
3D CRT, if not VMAT, with 3D CRT.
3D CRT, but for years, I always used concomitant boost. It's not perfect from a dosimetry point of view because you have some overlap of the dose, but I use for years 55 gray, meaning 50 to the, or 45 to the prophylactic lymph nodes and to the GTV plus some margin. That means 2 centimeters below, 2 centimeters over the tumor, and the corresponding mesorectum, a dose of 55 in the same time. The treatment was well tolerated, apart from patient treated with capecitabine plus oxaliplatin. For some time, I have to admit that I used this combination. It was really a little bit toxic. We had 40% of complete pathological response, but we end up concluding that use this regimen only for very high-risk patients, young, fit, and whatever.
Thank you. So a few words about radiotherapy in rectal cancer. So we need to cover the notes. You can see why we use this field. But if there's a APR, then we need to lengthen the field lower so that we cover the whole scar. And then on lateral field, you can see for T3, we don't take the external iliac. So the field is behind the symphysis. But when we is T4, we take the external iliac. It goes and in front of the external iliac, in front of symphysis pubis. Another thing, normally we cut the posterior end on S23, but in rectum, we need to take the whole sacral hollow. So these are the few small but very important tips that we need to keep in mind. So as Professor Aziz was telling, in normally field is L5S1, inferiorly 3 centimeters below the initial tumor or inferior obturator foramen. Laterally, we all know 1.5 centimeter, and posterior already I said what is the principle of T3 and T4. Normally, if you do the boost, normally it is recommended to 2 to 3 centimeter margin on all the direction. Posterior border during boost, we need to take the whole sacral halo. We cannot depend on the 2 or 3 centimeter expansion because we cannot avoid the posterior sacral halo. So
just a minute. Regarding the boost issues, so is it all about 2 or 3 centimeter margin, or there is some issues regarding the mesorectum? Should we include all the mesorectum within our boost field? Professor Alicio.
As I mentioned before, you have the tumor 2 centimeters below, 2 centimeters up, and all corresponding mesorectum. So not all mesorectum, but 2 centimeters up and down.
So
okay.
Just to, I totally obviously agree with Dr. Kamal. I would just would say, yes, T4, you have to include external iliac lymph nodes, just in the case where there is an infiltration of central pelvic organs. That means bladder, prostate, vagina, uterus. If it's T4 due to involvement of the sacral bone, you don't have to include the external iliac lymph nodes, but you have to include all the sacral bone because there is a risk of infiltration in the nerves, and a recurrence can be very, very painful in these patients.
Thank you. So very important that we need to take the whole mesorectum along our target, that is the tumor, and 2 centimeters up and low, not beyond that.
Sir, what about inguinal nodes, sir?
Sorry?
Inguinal.
What about inguinal nodes?
Inguinal nodes, I would consider in this case, because in case of gross involvement of the anal canal, we have to consider that anal canal is going to the inguinal nodes, or in case of involvement of the lower third of the vagina, because all these organs have this kind of.
Okay.
But it's something with the VMAT is relatively simple.
Thank you. Sumon.
Yes, Kamal, proceed.
So this is a few slides I have taken from e-contour, steps of contouring, that we need to first work on the GTB. MRI is very useful to fuse, to identify, and their suggestion is to start from the bottom. So first identify the lowermost area, and then if I have a colonoscopy report, the suggestion is that we should identify and see the length from anal canal to the tumor lower end, so that whether we are correctly identifying and it is corresponding with the colonoscopy report. So this is the technique they have shown. How can we identify the distance from anal canal to the lower end of my target area, and we can understand we have reached the correct thing. So then they said that in mesorectum, if there is any visible node, we should contour it. And it is interesting way they have shown that to draw all the vessels from common iliac to all, it is a fun and it is a good thing, so that when you are drawing your field and other things, this vessel will give you an idea. So once we draw, the vessel looks like this: external, internal, iliac eye, and all the draining vessels. So then we need to follow the vessels, and then we need to continue. They have recommended 3 CTB-A when we have confined up to internal iliac, but whenever we are extending up to external iliac, they are taking CTB-B, and CTB-C is an inguinal node. That we already discussed that in T4 we take CTB, that is external iliac, and when there is a anal bar lower end, very extreme low, then we need to consider inguinal nodes. So this is how they have shown that we need to take the mesorectum, and anteriorly we need to take some margin, and even during the bladder we need to take some margin. And then this is how they will cover the nodes. So how to take the margin, and then how to crop up from there. These are all technical things we all know, but what I like is that they have given every steps, and finally they say that once you finish the volume, you need to check it on the plane to see that you are happy with the coverage and you are happy with the field size. Then I said, my friend Professor Alessio, we should apply our CS, that is common sense, that whether my so much incredible target is really matching with my conceptual field or it is missing. That is very important. So these are the reference. So in our case, this was drawn like this, and all the nodal station was drawn, and the tumor was drawn. So MRI was fused. With the help of MRI, we identified the nodes, and finally the boost volume was drawn. And this is the dose distribution by VMAT. And then this is the DVH. And we checked why we are going for VMAT. We found that there's the 2D and the 3D, and this is the VMAT. So definitely VMAT is giving us a very good coverage, and we can reduce the dose to the bowel bag. So this is the difference between the boost of VMAT and the 3D multiple fields, and then we decided to go for VMAT. So the history continues. The patient tolerated the treatment very well without any interruption, and 10/8/2020 chemoradiotherapy was completed. The patient was feeling better clinically and gradual relief of symptoms. And then after 6 weeks of time of the end of radiotherapy, we did the MRI. And the MRI report said that there is a partial response and there is still some residual tumor. Initially, our plan was to do a surgery. We discussed with the surgeon. Then surgeon proposed, why not we try total neoadjuvant therapy? Why to treat him now? Because anyway, we are going to lose the sphincter. Rather, you give some chemotherapy. So I was suggested by my surgeon partner, and we started chemotherapy. We give him 6 cycle Xelox up to January 24 of this year. And his CEA level was gradually coming down. And lastly, and 25-21, it was 1.16. On January, we did an MRI at the end of the chemotherapy, and we found that there is a good response, and they are telling there is some fibrotic change there. Not very definite comment about the residual. We did a colonoscopy. Colonoscopy was done, and colonoscopy reported that they could not find any tumor anywhere. So then on 3rd March, because of the COVID, it was delayed further. Surgeon was not available. His laparoscopic ultra low anterior resection with Hensuin colonanal anastomosis and diversion to colostomy was done. And now let us look at the treatment time. CTRT was up to 10/8/2020. Treatment chemotherapy was given up to 24 January. Surgery 3rd March. So if you calculate from the end of chemoradiotherapy up to the surgery, there was 27 weeks gone. It is not always a planned thing, but it happened. So now on 4th March, histopathology came, no residual tumor, resection margin is free, no metastasis seen. So it is a complete pathological response. So the surgeon was still not very comfortable. He was not convinced that whether he can keep the function of the sphincter. So he was still counseling the doctors further that maybe even after pathological response, you shall have to go for a permanent colostomy because you may not be able to control your, this sphincter. But things doesn't happen as we expected. It was wonderful. He had a complete response, and 25/5/21, the reversal ileostomy was done. Just a few minutes back, I talked with him. He is having a wonderful life. So up to here, Mostafa, do you want to make any comment?
So at first, congratulations for this great achievement. I definitely, I should say, but this is more like CS guided treatment rather than a very evidence based. But if you look for the evidence, what we have right now, we have a Rapido trial that have tried short course radiation therapy followed by chemotherapy, that is Xelox. But here you have tried after long course chemo radiation therapy. Then a certain point you have to think that why not to treat with a total neoadjuvant approach. So it is a more scenario guided treatment than a very what I should say conventional study based evidence based treatment. So thanks God that at last everything comes good. But definitely saving the sphincter is a great achievement. I will say, but if I would treat the patient, probably I won't go for this what I should say the very heroic approach. Rather I will be conservative with the very conventional treatment. After long course treatment, I will wait up to 8 weeks, then I will go for the
Mostafa, I think we've lost you for the internet connection.
So I think.
Yes, Mostafa.
So can you hear me right now?
Yeah, it's okay.
So I think I won't be so courageous at that time. Rather, I would follow the standard guidelines. But at last, the hero changed the scenario. So thank you, Kamal, for this brilliant outcome.
Mostafa, it was not a plan. I said it was not a part of the plan. Initially was CTRT long course followed by surgery at 6 weeks or 8 weeks. I thank my surgeon who was pushing me. Why not TNT? Why not TNT? He said, and he was reluctant to do the surgery, and the patient was very cooperative. So now let us have some question and discussion. When you give neoadjuvant total therapy to rectal cancer, do you sequence radiation chemotherapy differently depending on the tumor distance from the anal valve? Sumon.
So actually, Kamal, what we have right now. So there you can see that as per the NCCN or the ESMO guidelines, they have a mindset that who are those candidates whom you tried for the TNT. There's the very at the very extreme groups. There's T4 group, low lying, invading the levator muscles, circumferential is emergent positive, and the lateral lymph nodes involvement, EMVI positive. So these are the groups. Still that there is no guidelines who are saying that the TNT should be tried for this length group or that length group. So length, I am not sure, Professor Alicio may clear these issues. Length might not be the selection criteria for TNT, but definitely if the levator muscle is involved, lateral lymph nodes involved, all those bad features, if all those bad features are present there, definitely I will prefer the TNT. The objective is to get the complete clinical response as per the PCR to save a good quality of life, to achieve a very good quality of life.
Okay, sure.
Right.
So if you look at the timing study published in 2015 in Lancet, they have shown that the group who has taken 6 cycles of FOLFOX, modified FOLFOX, has the highest pathological response. And again, if you see the German trial, it was not a non-inferiority trial. They picked the winner design. They compared the induction followed by chemoradiation versus consolidation chemotherapy after chemoradiation. And they have shown that the consolidation arm was having 25% pathological response. In the OPERA trial previous study, they have, this is a funny study that both the arm is experimental arm and the control arm is the historical DFS of 75%. And if you look at the study endpoint, what I said, but they had a very interesting way of follow-up. They have gone very aggressive follow-up. And if we look at the final curve, no difference between DFS and distance metastasis-free survival. The only difference is the TME-free survival. So again, they have shown that when there is a consolidation, that arm has a higher TME-free survival, even the DFS and DMS is not there. So my question to LSO is, that can we give credit to the addition of chemotherapy or the time? Because the 6th cycle of chemotherapy has made a long time. Because if the chemotherapy was there to play, then at least this distant metastasis-free survival should have been more in the consolidation arm. But we don't see that. So is it, we are giving the credit to the chemotherapy, which was supposed to be taken only by the time. If you have waited, I know you are a believer of 3 months waiting time before you was to say. So here, before nobody did it, everybody was going for 6 weeks, 8 weeks, meta-analysis said 8 to 10 is fine. Nobody was going beyond 12. But here for the protocol, they have to go for 18 weeks, 6 cycle, 18 weeks. So then they have to wait. So what do you think? Is it chemo or the distance or both?
Okay, first of all, really congratulations, because I came 6 years ago to do some lesson. Now I'm learning from you, because sincerely, in this hospital, talking about total neoadjuvant therapy, they are too conservative. They have to do always the same thing, and they will wait, I think, other 20 years before changing their mind. So really congratulations also to be so brave to aggressively treat this young patient. I would say, there is just some comment. Yes, if we give chemoradiation and then chemotherapy, this increase the pathological response rate. And some years ago, we read this paper from Garcia Aguilar showing that giving chemo after chemoradiation improves pathological response rate. And so we organized a retrospective study in Italy, and we collected 2,000 patients, 2,100 patients treated with chemoradiation, no chemo, and then surgery. And we look at the gap between chemoradiation and surgery. So the rate of pathological response rate was around 6 weeks, 8 weeks was 15%. Over 12 weeks was over 30%, not far from the result of Garcia Aguilar. So we concluded, we don't know if this chemo is useful because it's chemo or because this chemo is just delaying surgery. It's just a way to spend your time. You could receive chemo or go for holiday. Maybe the result is the same. So actually, nobody knows, because just waiting and receiving chemo give the same result. Okay, your case is very interesting. So something else, how you decide chemoradiation or chemoradiation followed by chemo or chemo followed by chemoradiation in the total neoadjuvant therapy. You showed the result of the German trial showing that the rate of pathological response is higher if you start with chemoradiation. So generally speaking, I would like to start with chemoradiation. Then always using the CS, cases are different. You want the best downstaging, absolutely start with chemoradiation. You have some strange, sometimes that happen. You have a relatively small tumor, but with a lot of lymph nodes, maybe some lymph node outside the mesorectum, where the risk of distant metastasis is very high. In this case, I could consider the possibility to start with chemo. followed by chemoradiation. So it depends by the case, but generally I would start with chemoradiation because this gives me more time to develop a pathological complete response.
Thank you. Now we have heard from you, and we will put the recommendation here before we share it with our colleague. I kept all the slides blank as the recommendation that me and Mostafa will prepare from this presentation.
So,
All right.
Yes.
All right. Can we have a second opinion from medical oncologist Jahid
Yes,
bhai
Zahid.
regarding these issues?
Any comment here, Zahid?
Thank you very much. It is not my area, so I've been put on this spot. Just a few things as a medical oncologist point of view, I'm just going to say is that in some other solid cancers, we really go very gung-ho to achieve a complete clinical response when we are considering neoadjuvant treatment, like say breast cancer, where we know the achievement of complete clinical response or even achieving a complete pathological response, that is a fantastic surrogate in the good prognosis in future. But however, we seem to adopted a lower threshold of happiness with the rectal cancer, that if we can just downstage the tumor, we seem to have been happy with that, which was a historical concept with the radiotherapy has been the mainstay in the neoadjuvant therapy in rectal cancer. And there has been a number of phase 2 trials to suggest that neoadjuvant chemotherapy might have a role as well. But that idea did not seem to go forward until this OPERA and Rapido trial came into the effect. So from a medical oncologist point of view, I am very keen to see the role of chemotherapy in rectal cancer. Obviously, the adjuvant aspect has been very frustrating, that we have failed to show any significant benefit in adjuvant chemotherapy. And we know that adjuvant chemotherapy has been fraught with the compliance issue. And even with the Rapido trial, I think nearly half of the patient on the adjuvant treatment did not get their treatment for many reasons, once again highlighting the issue. So it brings the fact that if you want to give chemotherapy, it needs to be brought forward into the neoadjuvant setting. And the question is, is it induction? Is it consolidation? More evidence is more in favor of consolidation than induction. All I can tell in UK that yes, we are very interested. However, it's not been fully approved by NICE to go for TNT in UK. We are looking forward. As you've said, the question is do you combine long course chemoradiotherapy with systemic treatment, or is it short course with chemotherapy? I think the ESMO suggests short course followed by chemotherapy in their new handbook, isn't it, in the second edition? So yes, I'm from medical oncology point of view, I think there is something we can do to improve the outcome of these patients. And I fully agree there is a role of chemotherapies to define which chemotherapy, because there was one trial which looked at FOLFIRINOX, which was everyone felt is a bit over the top. So it needs to be doublet chemotherapy. I think that's probably most people will feel by common sense that's the right approach. And how long? You say 6 weeks. And if it's FOLFOX, 9 weeks. So again, can you wait that time? I think that's okay, because one thing we never fully understood is what is the optimal weight, even with after radiotherapy before the surgery. I suspect that's one of the things we're going to discuss today. Okay, but one thing is certain, that longer you wait, the more benefit you see from the radiotherapy. So that's all I've got to say. I'm very interested to see what's coming next.
Thank you, Zahid. So here we will go for the recommendation. Now, if rectal cancer. Sir.
Dr. Rai speaking. May I say something about sir. One of the, I just remember one of my case.
Sir.
He was about 40 years old. He had a fairly large rectal cancer. I don't exactly remember what we said at that time. The fellow was not agreed to go for surgery. Went to India, bellowed, they said surgery, they came back. Again, be a very different sides. He went, did everybody surgery. Asked him to go for surgery, but he will not go for surgery. I said, okay, come on, I shall treat you. I treated him as for pre-operative stress. I give him some treatment, chemoradiotherapy, for pre-operative way, and then I said, convince him. I give him 45 day with capacity, and then after again 6 weeks, I asked him to come back. He came back. I tried to convince him again for surgery, but he will not go for surgery. So then again, I gave him another 45 days, and still then he is on follow. Till about more than 6 years, is perfect all right. If PET CT has been done and nothing actually available, is something miracle like this. This is what I remember when I was so inform me about this.
So, sir, story started there, so we are following you. That's why we are becoming courageous to take steps outside the box and trying to help. And God is so grateful. I mean, we are grateful to God that He is helping us and we are getting good results. So we move because I have few more slides to discuss. Time is going very fast because the discussion is very interesting. So in total rectal cancer receiving total neoadjuvant therapy. So the $1 million question, is it a long course chemoradiation or short course RT followed by chemotherapy? So before going to that, I want to ask to our participants the poll question that when we treat, what treatment regimen do you recommend for locally advanced rectal cancer? Radiotherapy followed by chemo, then surgery, surgery with 1 week of RT plus minus chemo, surgery 4 weeks after RT plus minus chemo, chemo followed by RT, then surgery. So Shorna, please put the poll question.
Yes, sir.
Poll is there. It is just for fun. We want to see that how many of our participants are in favor of which group. Please try to answer. There are 5 options. No one is wrong. You can choose your one just to see how our participants are. Please participate because we don't have much time. Everybody is requested to participate. We will be there only for 10 more seconds. Okay, Shona, stop. So there was 13 poll. Maximum was radiotherapy followed by chemo, then surgery. And chemo followed by RT is also 23%. I mean, neck to neck fight and surgery. So 4 weeks, then radiotherapy, chemotherapy, that is also there. Well, that is a heterogeneous opinion, we can say. Now we come to next, that when we are using the short course radiotherapy, NCCN guidelines currently recommend short course RT followed by chemotherapy followed by surgery. Many surgeons are hesitant to allow a 4 months interval between radiation and surgery, given a worry for disruption and scarring of the tissue planes. So the question is it valid? Is a 4 month interval too short or interval to see significant disruption of surgical planes? If you look at this paper published in Radiotherapy Oncology 2020, compliance and tolerability of short course chemotherapy, short course radiotherapy followed by perioperative chemotherapy is the RAPIDO. We look at the outcome. They found that the surgical complication and post-operative complication between standard chemoradiation, short course radiotherapy followed by chemotherapy were found no difference. So the concern of short course chemotherapy then the surgical complication was not seen in RAPIDO trial. In timing trial also, if you look that there was no difference in grade 3 or higher surgical complication across all the groups. So even in short course, there was no additional toxicity. And WashU retrospective report, Annals of Surgical Oncology 2020, they have given that in rectal cancer patient treated with short course TNT and proctectomy, we found no significant association of post-operative morbidity compared to patient undergoing CRT. Short course TNT does not significantly increase the risk of post-operative morbidity compared to CRT. And in the non-inferiority trial, Stockholm 3, you can see that they have shown that although radiation-induced toxicity was seen after short course radiotherapy with delay, post-operative complication was significantly reduced compared to short course radiotherapy because this finding we suggest short course radiotherapy with delay to surgery as a useful alternative to conventional short course radiotherapy with immediate surgery. So Stockholm 3 was in favor of short course with a long delay. With this all, I would like to listen from Professor Eliseo that if all this option for TNT, if somebody want to go for a TNT, what will be our combination? Shall we go for long course consolidation or short course followed by chemotherapy? Professor Eliseo.
Again, it's a matter of the patient and a matter of surgeon. The fear of the surgeon depends by the surgeon. It's totally different to work with a surgeon dedicated to colorectal surgery, a general surgeon, an oncological surgeon. Just to give you an example, years ago, I was working with a man, a surgeon dedicated to colorectal surgery. At some point, he started sending me patients with stage 1 rectal cancer. And I told him, I cannot irradiate them. And he replied to me, but you know what? I love operating patients after radiotherapy because this nice edema helps me so much to find the perirectal fascia. Everything is simpler for me. Please, please, please irradiate them. I told them I can't. But just to tell you how things can change. In this hospital, there is the old, I cannot say old, okay, the senior professor of surgery who is ready to operate after 12 weeks, 2 months, 3 months, no problem for him. After a short course, he has no problem. The youngest are very scared. What's this short course? We never reset patients after a short course. And so I had to go to this professor and tell him, you know what? We are doing something strange because we are treating all patients with long course, with surgical resection after 6 weeks, 8 weeks. This is strange. And so he had to write a law in his own department. No one can be operated before 12 weeks, and we have to accept to reset patients with after a short course. So it depends strongly.
Thank you.
Bye. And I use a short course radiotherapy. Actually, I love it in some particular situation, because if let's say a female patient, 75-year-old, T3N0, why should I give to this lady chemoradiation? She's old. She doesn't have problems of sphincter saving because the tumor is already high. So in this case, it's simpler, it's faster, it's better for me in terms of waiting list. So everyone is happy. It depends by case, patient, and surgeon.
Thank you. So which patient would you wait for watch and wait versus surgical resection after chemotherapy for rectal cancer? So if you look at this data, that is interesting data I found, that International Watch and Wait database, that highly selected database for major expert rectal cancer centers. Out of 880 patients treated with complete clinical response, 25% had brocal relapse. Most of these had C3 disease with 35% clinically N0 and 31% clinically N1. The best possible outcome is 25% local recurrence, despite 5-year survival is 94%. We don't know how many suffered as a result of local relapse complication or whether resection would have prevented this. So they commented that a controlled trial is desperately needed. So comment from you, Professor Eliseo, about the watch and wait.
Okay, the growth randomized trials are desperately needed. In the last 50 years, we desperately needed a randomized trial between surgery and radiotherapy in prostate cancer. I know it's a totally different field, but you know, when you have to replace surgery, you always find these problems. So you can find some surgeon ready to go for watch and wait, but it's very difficult to design a randomized study where surgeons will put their patients. About your previous question, again, which patient would you candidate to watch and wait strategy? Again, it's a matter of reliability of the patient. These patients has to receive a very intense follow-up. So if they are living close to the hospital, or if they are living in a village on the mountain, they don't have money, I'm not sure that I can enroll this patient in this strategy. So again, is a CS.
Thank you. So if it is a rectosigmoid tumor or very superiorly positioned rectal cancer, so this is a situation where we are not sure, is it a rectum or a sigmoid? So because if it is a rectum, we give radiation. If it is a sigmoid, we don't give radiation. So what should be the take of Celesio?
Normally, we take the MRI and we say, is some part of the tumor inside the mesorectum? Yes, okay, is also a rectal cancer. No, it's just a sigmoid cancer. I will not treat with the radiotherapy. In terms of target, the only difference is that if the tumor is high, I will remove the obturatory nodes from the target. I will treat just presacral, mesorectal, and internal iliac, but I can avoid to irradiate the obturatory nodes.
Thank you. So
Kamal, just a point. So
please.
Kamal, just to share one of my experience. So recently I have got a patient with higher rectum. So it's really high. Colonoscopic findings are around location is around 14 centimeter to 10 centimeter, just like that, upper rectal lesion, but no pelvic lymph nodes. So as it is T3 disease, no N0. So I have opted for a short course radiation therapy. When I went for a simulation, interestingly, I found a para-aortic nodes. So I came to know why this happens. So I discussed with radiologists and some surgeons. They give me a point of discussion that the the higher rectal nodes usually drains through the superior rectal nodes to inferior mesenteric vessels. So there might be a possibility to para-aortic node involvement even with any other internal, external, or pelvic nodes. So what to say about this scenario, Professor Alessio?
I don't know. Irradiating the aortic nodes, I never do it. Also in Agar tumors, it's outside any guideline. So it's very. You are very right. I understand it's an interesting case, but we are completely outside any guideline about contouring of rectal cancer.
Okay, Sumon, what I have gathered that the data says that the local recurrence decrease substantially when the tumor goes up. Even T3 in one tumor, local field is extremely low. And as Professor Alessio was telling, more we go up, if we are radiating, we can sacrifice some of the lower end, but we need to take care of the mesorectum. That is the recommendation. So another question, very silly question, that is there any time frame that within what time of the radiotherapy we should give capacitamine? 1 hour before, during, or something? Sumon, any comment on it?
So actually, I don't have any straight answer. Usually, I practice 1 hour before radiation therapy, but I don't know what the rationale behind it.
Yes, I found an interesting paper published in 2007 by Manpreet Bedi, and they have taken 111 cancer and they have given the capacitamine in 2 times and also shifted the radiotherapy timing, and they found there is no significant difference of timing of the capacitamine and the radiotherapy. It's not a great thing, but it's an interesting paper I found, so I thought that I can bring it up. Like temozolomide, probably there is no such need. Professor Alessio, any comment on this?
No comment. No, I don't know. We used to give morning after.
You treat rectal squamous cell carcinoma at the same like rectal adenocarcinoma. So here again, we want to go for an opinion poll. Shorna, next poll. Very quick, only 30 seconds. Question 2. So what we will be doing, that So we can go for definitive chemoradiotherapy, or we can go preoperative radiation. So 60-40, 40% went for CRT, standard treatment, and 60% went for 5-FU capecitabine, followed by surgery as per. So we look at the evidences. It is said that the largest analysis of rectal squamous cell carcinoma today. First, they say that we should be very cautious before declaring that it is squamous cell carcinoma of rectum when low-lying, whether it is anal canal or not. That's very important. But if you are really sure, they say that non-surgical RT-based treatment is recommended, recognizing that prospective data for this rare tumor will be difficult to accrue. Future population-based analysis should be done well. So this paper is in favor of doing chemoradiotherapy, radiotherapy treatment first. So if it is a squamous, we should not go for surgery first. We should try to give radiotherapy first. Okay. So in rectal carcinoma receiving total neoadjuvant therapy, do you prefer chemotherapy followed by long course chemoradiation or short course therapy followed by chemotherapy? So here again, the sequencing, and if we look at this Polish trial, they have found no difference. And if you look at the Rapido, there was difference in response and significant, not the difference in the survival 3 years. And if the German trial, they have shown the PCR is different. So, I mean, again, these were in favor. OPRA is also in favor of consolidation, but the only paper that is French Prodigy trial, they found that the induction is giving a benefit. So there are many debate on this, that as we already discussed, chemoradiotherapy followed by chemotherapy or induction followed by chemoradiotherapy, that was already discussed by Professor Alessio. So that we brought that it is not a conclusive, but majority is in favor of chemoradiotherapy followed by chemotherapy. Am I correct, Professor Alessio?
Absolutely, absolutely.
Okay.
From particular cases with extremely high risk of metastasis and a small tumor.
Okay.
Small primary.
So now a few quick questions from you. So if the patient comes after surgery, preoperative, it was a T3N2 or T3N0. Do I need anything to change in my radiotherapy practice, the dose or anything, or boost post-operative?
Is there a question for some?
Yes, Professor Alessio?
Yeah, tailor based on initial staging. Yeah, probably yes. I would be ready to give a boost in larger tumors, in tumors with a small margin, and consider that with post-operative radiotherapy, the local control is lower compared to pre-op, so the risk is high. If feasible, I would like to give a boost to every patient, reaching again this 54, 55 gray post-op, apart from relatively small tumors with maybe lymph nodes. In this case, I don't have to go so up.
So as you said that it is a post-op case, why we are going to give the boost? Because if the surgeon has taken the mesorectum, tumor, everything. So is it the anastomosis or anywhere else you want to give the boost?
Anastomosis, yes, and yes, anastomosis mainly. Again, with the 2 centimeter, and I cannot say mesorectum because mesorectum is supposed to be removed, but that area around the anastomosis.
Okay.
Up to the sacral bone, because you know most recurrences are in the anastomosis or in the pre-sacral space and in the vagina in female. So these are the area I would consider.
Mostafa, induction chemotherapy given. One patient was a good responder, then surgery done, then came for adjuvant therapy. Another, not at all a good responder, surgery done. Will you make any change in a radiotherapy plan? Post-op.
So it will depends on the initial staging.
Initially, both is T3N1, so N2.
T3,
So one
T3N1.
after, and if during surgery, one group found no nodes, tumor shrink, another group, all the nodes are there, even after induction chemotherapy.
No.
Will you give
I
any
think,
difference in the radiotherapy?
No. I don't think that depending on the response, I will not change my treatment plan. It will be
Professor,
both.
Would you like to make any change beyond the good responder and the
No,
bad
I
responder?
agree with Dr. Sumon. My only question is why this patient received induction chemo before surgery?
For any reason,
Right.
patient came, induction, then surgery came to me.
Okay.
It is real life. Every day we are getting this type of.
Yes, it's true. You're right.
So we don't need to tailor anything. So no induction chemo, very nice case, surgery done. Unfortunately, one is R0, one is R1. Are we going to do any change in the radiotherapy? Professor Alessio.
Yes, R0, it depends by stage, by margin, by extension, so on. R1 absolutely boost up to 54, 55, almost.
So, I mean, I was interested to have more discussion with Mostafa. I intentionally skipped some of the discussion with you because you understand we are.
Just one question.
Yes.
So if a patient is really unfit for surgery by any means, whether there is multiple comorbidities or not, from the very outset, if we think that the patient is not in favor for any circumstance, is not fit for surgery. So in these circumstances, whether we should increase our dose 54 to 60 with the intent to mind that the radical dose might give a total complete response, Professor Alessio, with all the TNT treatment, with all chemotherapies, but should I get some extra dose to rectum just to avoid the surgery?
Yes, absolutely, because we know that we can cure up to 30–40% of patients with chemoradiation, but we know the rate of pathological complete response after 8, 10, maybe 12 weeks. But what if we wait 6 months, 1 year? You know, radiotherapy continue to give effects. I had a patient with adenocarcinoma in the anal canal, and I tried to avoid colostomy. She was candidate for chemoradiation and then surgery. This is the only patient I remember that I treated with 55 grain and chemo concurrent, and she had a complete resolution of her cancer. And this story was 8 years ago. She's still sending me some nice food, and so she's happy, I'm happy, and everyone is happy. So we actually we can cure patients with it's important to avoid nihilism. Huh? Don't say, this patient cannot receive surgery, so why should I treat with radiotherapy? Treat the patient with radiotherapy because you have some chance. I had some patient, 95-year-old, no possibility of surgery, no possibility of chemo. I treat them with a short course. Some of them, after 3 years, had no cancer, no symptoms, no anything. So always consider to use radiotherapy, irrespectively of the possibility of surgery.
So Mostafa, in breast cancer, we know that there is a meta-analysis that have shown that complete pathological response can be now act as a surrogate for survival. So what do you think about the pathological response of rectal cancer? Can we treat it as a surrogate of survival?
I wish. So far I can say, but still we have to wait a long time to say.
Complete pathological response, saving the sphincter, watch and wait. Is it something to relate with the survival?
Yeah, as I told you, we have to wait for some 500 years before having a randomized study. But all evidences are very nice, and so yes, I would consider it.
Zahid, any comment about this rectal cancer, complete pathological response. Anything to do with survival or no?
I think I indicated at the beginning that a complete pathological response is proven to be a good surrogate for many other cancers. So why it shouldn't be in rectal cancer, but I also agree that we do not have any evidence to support this notion yet. So if you look back the OPERA trial, that it didn't show any significant difference in the overall survival in 3 years. And if you try to explain that, you might want to consider that a local recurrence will not going to kill the patient. So that makes sense that it did not make any, but if you also look at the metastasis, it reduced 7%. And then you want to think, okay, if we can reduce that, and if you want to look at further long-term data, like 5 years, 10 years time, we might see the impact much later, not right now. Now, one thing I think we forgot to discuss is the locally advanced rectal cancer that before the TNT era, 1 in 4 patients would develop metastatic disease while they're waiting for their surgery. Okay, and that meant 2 things. One is that patient will not get the surgery, and obviously number 2, that's in palliative setting more often, and you try to treat palliative chemotherapy, which will further affect their overall survival. So now that we have the TNT, and if we can refine the TNT, and if we can come to a consensus approach, if we can really reduce this metastasis development while waiting for surgery and while also achieving the complete response, I think we should see a significant difference, maybe not at 3 years' time, but it'll probably take another 5 to 10 years' time from the rectal cancer diagnosis to see how much it affected the overall survival. I hope it makes sense.
Thank you, Zahid. So rectal cancer is an interesting area. We can see that surgery is doing great job. And before the first German trial, we were always mostly giving adjuvant radiotherapy. Then it came up that the toxicity is less in neoadjuvant, so it came up neoadjuvant. And then the watch and wait made another bang that such a good response can be keeping for watch and wait. Then the new thing came in the TNT, the chemotherapy, giving higher pathological response, not a very promising survival. So I think, yes, Zahid.
I was just going to say that I don't think we have mentioned GRECA2 trial, because GRECA2 also talks about watch and wait, local excision, those kind of approach. And that's something very interesting that comes in hand with the OPERA, that in the GRECA2, just very quickly, I know you're short in time, that when it's a low rectal cancers, when you achieve a significant response 2 centimeters below the residual cancer, so the question is, do you watch and wait or do you do local excision? And there's been a big debate which one is better, whether you watch for the regrowth and then you do the excision, but in that case, it's going to be a TME, or it will be a sphincter removing surgery. Whereas you can do the local resection, you can keep the sphincter function, that will have a significant impact on the quality of life. And overall, I think the GRECA2 trial showed that there was no difference in the outcome between the 2 approaches. Sorry, just wanted to mention that.
Thank you for bringing up, because it was flooded with so many evidences. It was difficult to pick and choose, and the time is an issue. So now we are going to end our session by discussing about this nice-looking lady, Sharon, but she has another recognition.
You stole it from me.
Yeah, I said I gave the disclosure. I used some of the slide, so this is your slide.
Yeah,
and this is the Sharon protocol. Is I will say the invention of Professor Alessio and his team, short course accelerated radiation therapy, and it has shown quite promising result in palliative setup. And this 2021 in ESTO, it is going to be presented. So very quick, some comments about this Sharon, Professor Alessio. Why not to take the chance of disseminating the concept of Sharon?
Okay, Sharon is just a way to shorten the treatment time in palliative radiotherapy. We are using this, we are now testing, after several phase 2 studies, we are testing in randomized trials. So whoever is interested, please write to me. We can share these protocols. What is important is, apart from Sharon, the role of palliative radiotherapy. They asked me in our region to write the guidelines of radiotherapy. So there was a chapter of surgery, radiotherapy, chemotherapy, and palliative therapies. And palliative therapies has been given to anesthesiologists, palliativists, and so this kind of people. So I told them, I can write this, but I would like to write also this. And they asked me, why? Are you a palliativist? Response is yes, because radiotherapy has a big role in palliation also of rectal cancer. Bleeding, pain, obstructions can be so easily treated with radiotherapy, but people doesn't know. Almost in Italy, they don't know that radiotherapy, because you know it's so cheap, no one is taking money, and so why should we send a patient for radiotherapy? Or maybe they have some problem like, this patient is symptomatic, I cannot refer to you because you will treat him for 1 month and a half. Which month and a half? I treat him in 2 days with Sharon, in 5 days normally. So which problem you have? Send me this patient. I can do a very nice job.
So thank you. So this is a BID dose 5 grade. This is and we have seen that it is doing a great job. And we discussed many times that in Bangladesh for palliative, this could be a wonderful protocol. This is for rectal, it is for esophagus and head and neck. Many sites, if you look at this paper published in 2018, there's a pooled analysis for all that thing. So I think before we finish, I would like to ask our academic partner to make some comments. And I think, Sumon, if we agree, there are so many questions in the chat box which we didn't address. Shall we take it or we stop it?
Probably there is no vote of thanks today from the scientific partner point of view. So I think we can spare a few more times.
So there was a question of Arman Chaudhary, even we are not talking on anal canal, that whether there is a benefit of 3D CRT over 2D or anal cancer. Sumon, would you like to take it?
So I think in anal cancer, 2D or 3D doesn't make any difference. But only one question that in anal canal, we need to include the inguinal nodes. So including inguinal nodes would be a challenge. So if you really consider a good quality of treatment, then 3D CRT even would not be effective. Then I think a very higher conventional, that is the VMAT. Otherwise, 3D CRT would be very optimum.
I mean, in anal canal, as far as I understand, if it is a IMRT, then this is going to make a big difference. Probably 2D and 3D is not going to make a very big difference. But yes, if you can separate the field of clockwise, then Professor Alicio for anal canal.
The 2D, 3D, okay, it's not a huge difference. So if you have 2D, treat them with 2D, absolutely. With 3D, you know, with lateral beams, you have to cover inguinal nodes up to the sacrum. So the advantage is just for some small bowel here, but you have to irradiate practically most of the pelvis. You have some advantage, but continue with 2D if you have only 2D. Actually, you have a bigger advantage when you move to intensity modulated, because you can spare the internal side of the pelvis.
So there is a question from Karthik to Professor Alicio, prone or supine position for radiotherapy?
2D, absolutely prone, because in this way you move the small bowel up. If you use IMRT, now we are treating patients in supine position, because you can avoid the small bowel just with the dose distribution.
Okay, so there's a question from a surgeon. If a patient of low rectal cancer having sphincter involvement after CTRT and chemotherapy got pathological complete response, can we go for sphincter saving surgery, Professor Alicio?
I will ask to your patient. Your patient went very well. So yes, the response is yes, absolutely. And there is nothing so painful. I saw 2 or 3 patients who had a mild, abdominal perineal resection, and then we discovered that this patient had a complete pathological response. It's really painful, really painful. So these are patients where I would push or watch and wait.
So I would like to request Zahid. Yes, any quick comments? Zahid, we are almost at the end.
Is it regarding organ preservation
Totally,
issue?
on the total discussion, you can have a.
Okay, all right. Sorry, I'm not going to hold up people very long. So just very quickly, from the medical oncology point of view, the rectal cancer has been dominated by clinical oncologists for a long time. And we are just now making some headway. Obviously, we failed in adjuvant setting, but the TNT has given us a little bit more option for the medical oncologist to step in. So right now, I think in rectal cancer, there's two things. The big issue, one is adding systemic chemotherapy before the surgery and whether that will improve the outcome for the patient. And the second thing is the organ preservation in rectal cancer. So we know about GRECA, we talked about OPERA, GRECA2. There is one trial we did not mention, Star Trek, which was some chemotherapy, systemic chemotherapy, and then followed by looking at various surgical options to see if we can avoid the TME. So I think these two concepts will dominate in the coming years in rectal cancer, is how we can reduce the risk of metastatic disease before the operation, and also whether we can actually avoid a morbid operation for this group of patients. I think that's all, and I think we need to aim high. As I said beginning, that we were relatively happy just to reduce the cancer from neoadjuvant treatment and then trying to do an operation. I think we need to aim higher now. I think we can see the horizon better. Thank you.
Thank you, Sumon.
Okay, there's only one thing. If we want to keep our patient and watch and wait, what should be the follow-up protocol?
You've got GRECA2 trial. I can send you the GRECA2, and also OPERA provides some idea how to monitor them. So if you look at the OPERA and the GRECA2, that will give you a really good idea how to monitor them. The one thing about the, it's an ongoing debate, is when you say a complete clinical response from an MRI, then ideally you need to check it with both DRE and also, if necessary, an examination under anesthesia. So only then you can say, when you've done an examination under anesthesia, taken biopsy, and you're not seeing any residual cancer, that's when you can say a complete response without taking the organ out, isn't it? So I think you have got some ideas from the OPERA and GRECA2. If you want, I can send the GRECA2 paper.
Thank you. It will be a pleasure, Zahid.
Thank you, Zahid.
Okay.
I mean, that was the thing that DRE, MRI, and if required, suspected biopsy. Somebody said also.
Yes, actually, there is some good news. For a couple of days ago, Lancet Oncology came out with a paper showing that in these patients that normally receive a follow-up every 3 months in the first 2 years, then every 6 months, a lot of exams, and now they show that as much time passed, after 2 years, if there is no recurrence, the risk of recurrence becomes smaller. After 3 years, it becomes smaller. After 5 years, the risk of distal metastasis or local recurrence is low, 2–3%. So probably after some time, we can reduce the intensity of follow-up.
Thank you, Professor. So we tried to bring many issues. I had many more questions and evidences which I could not bring for the time. But today we tried to design in a practical way that every person who has been joining, they can see the reflection of their everyday problem here. And we try to bring out the answer through some evidence and also with experiences. So I would like to request Professor Alessio to make a comment as a concluding comment, then we will finish this.
Final comment. Final comment is just thank you very, very much. I really enjoyed. I really learned something interesting. I think the conclusion is that we have to, in our daily life, we have to refer to evidence-based medicine, absolutely, and using some ability to modulate our treatments based on patients' characteristics, based on the discussion between colleagues, surgeons, medical oncologists, radiation oncologists, to give our best to our patients.
Thank you, our professor. Hi, sir. Can we finish it, sir?
Yes, it's high time. Thank you all very much. Very nice afternoon today. Nice discussions, very interactive sessions, and problems as a problem solving discussion. So thank you all very much for taking part in this. And a special thank to Alexandra and Jahid, and also all the participants for press, and thanks to our academic partners.
Thank you very much. Thanks to both the discussant, Dr. Mostafa, you have done a great job, made my life easy by responding to many questions. And so thanks to Alessio and Zahid to give the backup. Without you three, I couldn't have done the session. It was not possible because there are so many things challenging. And finally, I think we are grateful to all the patients from whom we are learning. Think of the patient that we started discussing. I was very frustrated to get this patient because he's a doctor's father and such a low-lying. After all the effort, I was waiting to offer him a bag. And he was scared of that bag. And nobody knew what is going to happen. You see, sometimes blessing in disguise. COVID came as a blessing in disguise. Otherwise, maybe he would have gone for surgery. First time delay was due to COVID. And it was due to COVID. So the surgeon said, why to wait, rather give chemo. So we went for that. Even after chemo, he had to wait for 1 more month for again the COVID, because Bangladesh, there was a peak and it went down. So we don't know actually what really happened, but end of the day, we are happy that this patient could have a normal life. As Professor Alicia said, these are the patients who are teaching us every day. We will look at the guideline, we will look at the evidences, but our patients, I think, is the best teacher. And we should give our best to give the most evidence-based, logical, rational offer to our patient. And we should explore everything before saying no to a patient. Professor, I love the word Professor Alicia was telling, 95 years, try something. Cannot do a surgery, try something. I mean, today we cannot say no to anybody. Scientifically, there are so many options. And it is a continuously evolving area where one cannot keep the track. So I request our juniors to join in this platform where you will be educated by the sleepless night of the organizer. This makes many sleepless nights to make half an hour presentation, which you will need few weeks to read. So, and also you are getting the knowledge of these overseas faculties, which is $1 million cost. Even you pay, you are not going to get it. So it is free of cost. It is a free lunch here. Join and enrich yourself. So with these few words, thanking to all the participants and the faculties, I want to say goodbye to everybody by inviting everybody to join next week. Probably we'll be talking on immunotherapy. Am I correct, Sumon?
Let me check.
Probably.
We will inform them later.
Okay. So we will be sharing with everybody. And again, Alessio, thanks for giving the precious holiday. And Zahid, to you, Sunday is an expensive time. Thank you very much.
Thank you very much.
Bye to everyone. Bye.
Bye.